Hi, everybody. Welcome to this fifth episode of the Surgeon to Surgeon webinar. So the aim of these webinars is to connect SECEC members with surgeons all around Europe and maybe in the near future, the world, to step in their OR and learn from their valuable experience. So today we have the privilege to be invited into Jean Mermoz Clinic to see Lionel Neyton perform a Laterjet procedure. So you can ask any questions you want on the Q&A section of Zoom, and we'll relay them to Lionel. And also, we will first see a short presentation video for the installation, which is a crucial part of this procedure. And then Lionel will present our case and go ahead with the surgery. So let's go ahead and have a look at the video.
Okay. So hello to everybody. Welcome to Hopital Privé Jean Mermoz in Lyon. I'm Lionel Neyton. And we present now a video of the patient installation on the table, which is one of the crucial steps before performing a Laterjet. So you see that I put a little towel behind the medial aspect of the scapula in order to reorientate more in the frontal plane the scapula, and I make some tries. I'm make myself in the right position for the procedure before starting to change the position of the patient. The patient is not in the lying position and it's not in the sitting position. It's quite intermediate position, but still quite lying, because the more you are sitting, the more the anterior, the shoulder is itself positioning and anteriorly, and we want it on opposite to be dropping in the back. So I use a very simple U-shaped arm holder that we position on the lateral aspect of the table with a sliding locking system. And the goal is to have the U-shaped arm holder at the level of the elbow, and therefore I would be able to use it for the time of the split of the subscapularis to be in the muscular part of the subscap, to be in full external rotation, elbow at side, like you can see on here. So we can make some different adjustments so that the height is good, and until it's not good, you change and you readjust the position. All right. So when that's okay, you just finish the positioning. I think it's okay. Okay, so we're back live now, and so this is a patient. She is 35 years old, so it's a lady. She's a web developer. She is involved in sports, and she plays badminton, and also she is a swimmer. She complains about left anterior instability. So she, in fact, initially developed this anterior instability story in the context of epilepsy. So we know that we don't like this too much regarding the surgery because of potential recurrence even after the procedure. So the point here is that we accept to do the surgery at least when what the patient has 1 year completely clear with any seizure episode for at least 1 year. So the last episode was recorded in November 2023, and she is followed by a neurologist, and she's completely balanced with the medical treatment since then, and she had no recurrence of seizure since then. But nevertheless, she still complains about the shoulder and instability with significant apprehension in, of course, sports activities, but also daily living activities. And that's the reason why she wants to be fixed now. And we can understand the instability feeling and symptoms when we see the lesions. So next slide, please. You can see here a CT arthrogram she got before coming to me, and you can see that significant Hill-Sachs lesion, but also glenoid bone loss. So it means that she has bipolar lesion, clearly off track. And you can see here the Hill-Sachs, which is quite significant, and the glenoid bone loss. So for me, this is a good indication for a bony procedure. I would not consider to do any scope soft tissue fixation in that kind of patient. So here we are back in the live surgery. So the landmark is the tip of the coracoid process that you can palpate with your thumb or index finger. And from here, we go straight vertical relative to that tip of the coracoid process. We don't do oblique because the goal is to expose the glenoid and not the joint line itself. So we have a better way to expose the anterior inferior aspect of the glenoid where we want to put the bone graft with a straight incision. So this is time for incision. Let's go.
Lionel, any indication where you will put your incision more medially, for example, or more distally? You always do the same?
No, obviously we do always the same. So one of the key steps is in the Laterjet procedure is that it's a difficult procedure, but you have to make it easy as possible. So which means it starts by making the hemostasis right away, and every single thing that bleeds needs to be stopped right away in order to avoid a bleeding wound.
Do you do any tranexamic acid?
Yeah, absolutely. So until you are at the level of the muscle, meaning deltoid and pectoralis major, you just go straight like this in the fat, soft underskin tissue. Pince à disséquer, s'il vous plaît. So we start to see the fascia here. So beyond the fat, we're gonna be at the level of the muscle plan. Okay. So here, prends plus profond, s'il te plaît. Okay, so here we see the pec. We don't see yet the delt, and we're gonna elevate here. So you start to see a yellow area here. So it means that we're gonna have the delt on the lateral part and the pec right here. So don't try to start to find the deltopectoral interval in front of you. Always start to find it superior and medial, which is the Moranheim fossette. It says well known now. So this is a triangle area with only fat, and it's the entry point of the deltopectoral interval. You can use this in the Laterjet procedure, but you can also use this in any open procedure with a deltopectoral interval. So here we got a left vessel here. Alors here we're gonna replace this very superior and medial here to go here, and then you've got you got again the pec and the delts right here, and with the Metzenbaum scissors, we're gonna open here, follow the medial aspect, the lateral aspect of the pec, sorry, and stick to it in order to leave the cephalic vein outside, lateral.
You always leave it lateral. Sometimes you put it medial.
Excuse me?
You always leave it lateral, the cephalic vein, or sometimes you put it medial?
No, always lateral. Okay, go for it. Okay. So we start to have that little space being open over here. And I'm taking the time for hemostasis because I don't want to have bleeding for you to see really nicely here. Okay, so I play with my pickup.
Perfectly clearly.
Okay, je vais prendre le Richardson. So now at this point, I can take a retractor like here, and we see now the cephalic vein. Okay, buzz on me. Go. Okay. Take this one here, please. Suction. Yeah, for me. Pince à disséquer fine, s'il vous plaît. Okay. Buzz on me.
So Lionel, while you're
Left hand.
dissecting, because it's a lady, would you change the size of the screws, or you always take the same size of screws regardless if it's a man or a lady?
So the screws are 4.5. I will show it to you later. So the size, the diameter of the screw are the same, but the length is just depending on the size of the gland and the size of the defect, and this also according to the size of the coracoid process, and especially the thickness.
So it's something you measure. You don't go for a 32, 34 as a
Oh,
routine.
it's quite always the same, you know. Okay, change. All right. So here, no, something wrong. Okay. SECEC. So here you see that we can gain by putting the arm in abduction, can gain some exposure inferiorly, and we're going to stick to the pec major in order to avoid any problem with the cephalic vein, even though it's a little bit bleeding here. So here you see this the pec major here. So I'm staying at the level of the pec major, and we can go along downward here. I hope you can see.
You see perfectly well.
Okay, thanks. So now we're gonna go for it here, because the skin incision is not that large, but the space that you can create by moving the arm retractors is much larger. So here, okay, we don't have any significant crossing vessels, let's say, the way we call them, who are medial to the cephalic vein. We had a case this morning, which is a very large one. So if you have some significant vessels coming from going to the cephalic vein, you should ligate them and not buzz them. So very small little vessels can be buzzed or coagulated, but more bigger ones must be ligated.
Lionel, can you tell us why we call them the French vessels again?
Yes, absolutely. It's an old story from Brad Edwards, who was the American fellow of Gilles. And when he started to be in the OR with Gilles, he said, we never see this in the US. And that's the reason why he said this must be French vessels. Okay.
So this patient is maybe American.
Okay, take this one. So now we can put a self-retaining retractor, and we can start to see here the tip of the coracoid process and the conjoint tendon. So the coracoid process is really important, and we're going to ask for scissors. So we want to use it as a landmark. So we can, with the scissors, we can go up there with the pickup and elevate the tissue or above the coracoid process in order to put a simple classic Hohmann retractor over the top here. So basically, the tip of the Hohmann retractor is at the level of the CC ligaments. Now we're gonna work lateral to the coracoid process. So everything you do lateral from the coracoid process, you do it in abduction in order to relax the delt, and this will open that space laterally. So here, we're gonna open that fascia here. I'm grabbing here the lateral aspect of the conjoint tendon, and we're gonna open the space, and you can start to see here the subcoracoid space and the anterior aspect of the fascia in front of the subscap. So we can go up there in that little space here. Okay, suction over here, please. Now we're gonna have laterally here, we can start to see the CA ligament. So in order to see the CA ligament correctly, still in abduction, we are going to use a small Hohmann retractor, and we see here the CA ligament. I can palpate it with my pickup. I'm going away with the delt like this, and I'm following the CA ligament, and I'm going very lateral over the top of the acromion, and we open the space like this way. Pas trop, Antoine, tire pas trop fort non plus. Did you see it? Okay, so this is the trampoline of the CA ligament, and you can see that I have the full length of the CA ligament until its attachments to the coracoid process.
Perfect view.
So what I'm gonna do now, I'm gonna bend my like this, because here I want to harvest the longest part as possible of the CA ligament close to the acromion, because when you buzz to cut it, it retracts a little bit, and we don't want to have it too short. So here I'm cutting the CA ligament to release it like this way. Now this is done, I can unbend my here. So you see here,
Lionel,
yes?
Using scissors for this stage, you want to avoid because of the bleeder you have at the back of the CA ligament, correct? Using scissors.
Oh yeah, it's gonna be. So this is the next step, because here you start to have to see this the underlying CH ligament. You can start to open it a little bit like this with the buzz, but it will be cut later on. So now that we have done what we want to do lateral to the cricoid process, we can remove this. So the delt comes back, because now we are going to work opposite, medial to the cricoid process here to release the pec minor. So in order to relax the pec minor and be able to open that space medially, we come back with the elbow at side right here. Okay. So now we've got again the tip of the cricoid process, which is right here. I'm going to show you the pec minor that comes from inferior. See, it's oblique direction like this. So here, now we locate the tip of the cricoid process with the electrocautery device. We're not gonna open in that area here, which is medial to the conjoint tendon. We're just gonna open the space, the little here pec minor insertion, and here I grab it with my pickup like this, and I'm following the bone. You can have a little retractor here, griffe.
So it's important always to stay to the bone here, right?
Yeah, you stay close to the bone, because we know that under the pec minor we've got the brachial plexus, and of course we don't want to have any problem there. So here you can see that with grabbing the pec minor, pushing it medial like here, we discover the fat, which is the beginning of the brachial plexus, and we don't go in there, and we just follow the line of the bone, the horizontal part of the cricoid process, right?
Perfect.
So
Lionel, in my personal experience, especially in ladies, I find the musculocutaneous nerve is much more pushed laterally. I don't know if this is something you've experienced as well with women. Much closer to the subscap than.
Yeah, it can be.
Extra careful.
It can be. So here I take a bone elevator like this. Okay. So we're gonna work here to create the subcoracoid space and start to open it just with the bone elevator. All right. Now it's time for the osteotomy of the cricoid process. So because you can have a bleeder, we have it there. I'm going to use the suction as a retractor. So the way I'm using it is that I'm pushing it posteriorly and inferiorly, and you see here it's opening the space, and we use that angulated saw, 90-degree angulated saw. So my goal here is to have that part of the saw here, which is gonna be parallel to the long aspect of the cricoid process, right? You see it there. So this is gonna be parallel to this. So I'm coming over here. Around, we take the full length of the horizontal part of the cricoid process. So now we come over here, and basically we let the saw do the job. So you take your time, it's gonna come, no rush.
We can see a really decent sized graft here at the level of the knee, at least.
Yep.
Can you comment on the use of a saw or a burr? Because I've been taught to do this procedure with a burr, with the osteotome, and I still use it. What is the advantage for you of using a saw?
Because it creates a straight saw. I have very, very little chance for fracture or for bad line of cut. regarding because the 90-degree angle by definition. So it's for me, it's the most efficient way to have a reproducible line, and therefore to control the length and the size of your graft. So now you can remove this. We're going to use that curved osteotome into the osteotomy line, and we twist it to make sure that all the bony bridges are free. So now the coracoid process is free, but it's not free yet. Why it is? Because we still have the attachment. You see, I can pull on it. Even though the bone is cut, it's still attached to the patient. So how to release it? Now we go back in external in abduction. We are going to elevate the deltoid like this way. We flex the elbow, and by a good grab by this clamp, we can work. Alors, je fais un peu plus comme ça. So I'm grabbing the coracoid process, and not to stress the musculocutaneous nerve, I keep my elbow flexed 90-degree. Suction, please. And here, this is not the easiest part of the procedure. Go for it, yeah. Because we have to keep the CA ligament here, but we have to cut the CH ligament, which is just behind. So I don't know if you can catch it, but I'm really strong. I'm having a strong pull effect there.
Absolutely.
Okay, and I'm staying in the back of it, and yeah, and at some point the CH is released, and then you can lift your coracoid process. You see the way it is? It's going now.
Absolutely.
Okay.
This is a step of the procedure where you can see how strong this ligament is, because there's really no way you can
super
get this
strong
bone block out without releasing it.
It's very super strong. So until it's released, you won't be able to have any mobilization of your bone graft.
And Lionel, do you have any tips regarding the bleeding of the stump of your bone block? Do you use bone wax or anything like that? Or
absolutely, this is where we are now. So here I'm just controlling that I don't have any active bleeding from a vessel, which is actually the case here. So this that I can control right now, I'm going to do it. Buzz on me, please. Over here. From the top. Okay, but the bleeding from the bone here, I cannot really control it, and I don't like the wax. So what I do is my PA is having that sponge this way, and we just put it here. We remove the Holman retractor. So basically this will be against the bone. With that retractor, we just push it this way, and it's gonna be there until the end of the procedure. This is the coracoid, this is the sponge that we are gonna remove at very last step of the procedure. So now, and it's providing a hemostatic effect. So now we need to understand that the coracoid process is not still free. Despite we cut the bone, despite we cut the CH, we still have some soft tissue to release on the lateral aspect of the conjoint tendon. So Lucas, you take this way here. So you can mobilize the conjoint tendon like this, superior and medial, to expose here the lateral aspect of the coracoid of the conjoint tendon.
Okay, Lionel, we have a question from the audience, from Brian Waterman from the US. So he's asking about this great-looking clamp that you have. I believe it's like a Muser clamp, because they don't have them in the USA apparently. So what kind of where did you get this from? Is it manufactured by Arthrex or?
Alors, I'm gonna answer you. You can have a longer one. I have a conflict of interest because I designed this one. So in the very beginning, I used the short one, but we're gonna use right now the long one to show it. Remove it. So this is a grasper. It's available, and it's longer so that the hand of your assistants are away from the wound, and you have a strong grab and strong grip on the coracoid process. And we're gonna use it a little bit later, like in 5 minutes for the glenoid prep, for the coracoid prep, sorry. Can you have it there? Okay, we still have to work laterally on the conjoint tendon. So we come from here. Oh no, I did it. So you see, sorry, pardon, j'ai oublié. Okay, so just to show you, cleared completely. There is no anatomic danger on the lateral aspect of the conjoint tendon, and we need to clear it quite low here. So you can, I see that you can see it correctly. Okay,
perfectly well.
We are down at the level. I can see already the axillary vessels. The three sisters are just over here. So we're gonna see them a little bit better later on. And here I'm releasing some little adhesions in the back side of the conjoint tendon and in front of the subscap. So now the bone block has been released and it's ready to go. What
about the medial side, Lionel? Do you release any more further?
Nothing on the medial side, except the release of the pec minor I did in the beginning.
All right.
So now we are going to work on the coracoid process. We don't want to work from here. The reason why we want the flattest part, which is on the opposite side, to go onto the glenoid. So we're not gonna work from here. We're gonna work from here. So in order to do so, we just put a simple sponge here to protect the skin, like this way. And we avoid also the contact with the Cutibacterium acnes that lives there. So we just flip the coracoid process like this, and we are going to work here now. So the next step is to make sure that we keep the CA ligament intact. So can you grab this one? And now I'm just gonna remove the soft tissue and subcoracoid bursa tissue. So yes, here, pince à disséquer, c'est un standard. Merci. We just elevate that fat tissue here, which is different, something different from the CA ligament, which is here. We can nicely make the difference between the two. Now we see the origin of the conjoint tendon here. We can start to remove this and also remove that soft tissue here. That's the first step. The next step here is that we're gonna work on the bone, and we want to choose the flattest part of the coracoid process. So what we're gonna do is that we take the CA ligament here, we flip it underneath this way, and I'm gonna grab my coracoid process here. So here for me, the rotation is no good. So what I'm gonna do here is to work in the correct axis here. Now my bone block grasper, or any grasper, is in line with the axis, the main axis of my coracoid process, right? So here, I'm just checking where this little spike here is, and then I can now remove it with the saw. Prior to that, I take a little 15 blade like this one, and we're going to remove and push the periosteum. Why it is? Because if you are here, you can say, damn, I took it too small for 2 screws. And this, in fact, this is not. Because why so? Why I say so is because you can push the periosteum and expose a little bit more of the tip of the coracoid process. So a coracoid process that will become the graft will be longer than you expect from here, and it will be fine for 2 screws. Okay? So here I just want to make a slight adjustment in my grab. Okay, now everything is okay, and now I want to create a flat surface. So to create a flat surface, we come like this. We get rid of that spike, number one. Okay, so now you see that curved. Okay, now I'm gonna go there distally. We can push a little bit the envelope right there to expose more bone, and you can start to see that nice rounded shape here. And in between, we want to remove the cortex. So we go for here, like this with the saw. There's absolutely no harm going down, further down here. You're not going to jeopardize the fixation, the insertion of the conjoint tendon. And here we're going to work like this to remove the cortex and avoiding to make the graft not thick enough.
So you want a nice bleedy bed, sorry, on the whole surface.
Yeah. We want to be in the cancellous bone rather than in the cortical bone. So we need to have we need to pay attention here for the prep.
What is your let's say minimal distance you would accept between two screws before you say, okay, this is too short, I'll go for maybe one screw?
I want 1 centimeter, and in fact it's a fixed you can remove this one now. I want 1 centimeter, and in fact it's a fixed distance by the jig I'm going to use. You can take this.
Sorry, I spoiled you, sorry.
Yeah, you're anticipating because you know the procedure. Okay, so now I just want to avoid any soft tissue interpositioning here. So we can take this little tissue here, leave the CA ligament intact, but just make sure that we have exposed correctly the bone surface. Okay.
We have this nice keyhole-shaped coracoid. Right. Sometimes you have a little wedge that on the lateral side. You get rid of it, like a little spike sometimes on the.
Yeah, if it's really spiked, if it's really spiky, yes, I can reshape it. So now let's have a look at what happened. So here I chose from this flip position, I chose the flattest part of the coracoid process. We know that the coracoid process has a kind of crazy non-symmetric geometry. And in fact, if you look at what happened compared to the coracoid process where it was initially, let's go and flip it again on oppositely. You see here, it used to be like this way. Okay, the CA ligament goes there, and this is my insertion of the pec minor. Okay, so theoretically, it was like this. We should have done, if we have worked from here, we should have done the two holes from here, and then flip and then prep. We did the opposite. And why we did so? Because if you look at what happened, but just by preparing on the flip side, look, it's 90-degree angulated. You see what I mean? This is completely different. Okay, it's not 90-degree, but it's not symmetric. Okay,
it's something to consider if you do this arthroscopically, right? If you do this step arthroscopically, you may not be preparing the right surface.
Right. So that's the reason why when you do this under scope, you have to really burr it. But depending on where you did your two holes for the fixation on the opposite side. So now let's see the rationale for that bone block grasper right here. You see these two eyelets. It's because here you can have the blade, the bone chisel, and now it has been designed to land just underneath like this. And if you flip it again, take this, you're going to be safe because we're going to drill now from here, and we don't want to have the crazy escape of the drill into the patient. So we take the Arthrex device, which gives you the 1 centimeter. I don't use it this side because it's not flat and it can toggle a little bit like this. So I use the flat side. So I'm using opposite to where it is. I'm going right in the middle. And let's go.
What is the size of your K-wires, Lionel?
357. 157, sorry. Yeah, not 3.
Okay.
I don't remember it because 157 is kind of crazy.
It's a very specific number.
Okay. Bend a little bit, pas trop. And now I come at the superior one. I make sure I'm in the bone. Okay. And then I can go and I'm stopped by the chisel. So we use the cannulation system. So you can see here where the position of my 2 pins are.
Yep, we see it perfectly well.
Let's go. Now we use the cannulated system, the cannulated drill. Okay. I make sure the chisel is underneath and we can go for it like this. Okay. Number 1, remove the pin.
So Lionel, we have a question from the panel, which is
Yes.
if the graft is smaller than 2 centimeters, let's say if your graft you figure is too small, what do you do?
If it's too small, it means that either you didn't push the envelope right here to gain the maximum, to benefit from the maximum length, and you can still have it. Or when you did you were too short comparatively to the position of the knee of the coracoid, which means that you didn't take the advantage to go posterior enough to expose the correct length of the horizontal part, and that's the reason why you've got that short graft.
So let's say the morphology of the patient is really sometimes a really very short, stubby coracoid process. Would you consider going freehand if the distance is too wide between your 2 screws?
Oh yeah, you can change it. You can change it, but honestly, it didn't happen to me. Honestly, you always have like 1 centimeter distance. So here we work from here, so we know where the 2 holes are. But now we're gonna work from here, so we don't see them. So the little trick is to take the bovie like this, through it, and then you flip in here, and now you see them, and you can make sure you're gonna see them from this side. So now we've got the prepped coracoid. The 2 holes are okay. The flat surface has been created. We've got our ciliary ligament right there, and the lateral part of the conjoint tendon is free. Take this. So now, as reported by our friend from Toulouse, Nicolas Bonnevial and his team, we're gonna embed our bone block into a sponge that is impregnated with antibiotics, vancomycin.
Okay. Did you do this? Did it change anything in your practice? Clinic?
Didn't have any infection so far.
How many cases did you do like this?
Oh, I don't know.
Since how long? Like many years?
Maybe 2 years now.
Okay.
Ouais. Around 2 years. Ouais, attendez, on va prendre le Richardson. So here now, the bone block with the sponge will be pushed medially. And now, very important, if you want to see the target, you need to be in full external rotation, elbow at side. So my U shape is there. Can you see it?
Yep.
Under the drapes. Okay, so I push it back here, medial. And now it's a fulcrum point for my flexed elbow and 90-degree flexed elbow. Okay, tu prends ça. So now, pince à disséquer forte. Oui, on va changer les gants. I must obey to Audrey, otherwise I will be in trouble. Okay. Thank you. So now we take the grasper and we're going to push that little baby medially like this with the retractor. We see here we still have some adhesions. Alors, tire pas trop vers le haut. We still have adhesions. We're going to show them to you here between the conjoint tendon and the subscap, because this is something that we could not see before because we were not in external rotation. So here, those adhesions, you release them from the lateral aspect. Like here, je vais prendre une pince à disséquer plus petite, s'il vous plaît. So this is the muscular part of the conjoint tendon. Okay. Okay, so I release it. There's a little fascia in front of the subscap. We can release it there. And now one little trick I like is that you take a sponge, and that sponge, you roll it on the subscap, and immediately you see the muscle belly. So the tendinous part is hidden right there. I don't want to see it because we're in full external rotation. I want to do my split into the muscle belly and through it, and I don't want to see anything else than muscle. So here, this is my sponge I just rolled. So I'm gonna remove it. Now we can change. Okay, pas trop en haut. You see the tendinous part is white and it's over there.
Yeah, we see it well.
Right here. I don't want to see it. Tiens ça. So we just make sure that we expose correctly the muscle. And now where is the height? So the height, we need landmarks. So the landmark, inferior landmark is there. The three sisters, you can see them. So the three sisters are the inferior landmark for the subscap. Number one. Number two, we can go like this maneuver here with the pickup, and you can see the upper part of the subscap.
Absolutely.
So normally in a non-hyperlax patient, we go, this is the way we were taught by Gilles, 2/3 in superior, 1/3 inferior. So here that patient is, she has actually 90 degrees of external rotation, even not in under general anesthesia. So I'm gonna be going halfway, so half.
So just to repeat for our viewers, you're in external rotation now with your arm, right?
Full external rotation.
Full external rotation, exactly.
Yeah, we just check that you see that correctly on the picture. Yes, you see? So this is internal rotation, and this is full external rotation. Elbow outside, really elbow outside here, like this. Okay?
Perfectly clear.
We have a little hemostasis here. So now split. We've got some fat tissue here. Okay, good. Relax. So that the height at half is there. So with the tip of the scissors, closed scissors, Mayo scissors, we just go through the muscle like this and touch base with the head. I can feel you see the rounded part of the head, which is right here in external rotation. Now, in contact with the capsule, I'm opening, and you see here the white nice capsule that comes into our view. Okay, so I need to do a better job here. Okay, now with the clamp, I'm gonna open that space here. So I'm pushing my pickup. I'm pushing my pickup beyond the joint line and in front of the glenoid. I'm starting to open that little space here. That space will be widened by using a full deployed sponge. So the full length of it. You see, I'm doing the maneuver here, and it's tagged with some sutures. So in between the legs of the scissor, in between the scissors, actually, you push the sponge in the subscap fossa, which means that we are in between the subscap and the scapula anterior blade. Okay, you can see that sponge going very medial. Okay,
amazing the amount of space you have.
So the space is created actually by the sponge. And now we just put the tag sutures because are medial. And now I'm going to use a standard Homan. So this is the first step of that exposure here through the split. So here I ask my assistant to push the Homan retractor in the back so that it's stabilized against the scapula. And like this, okay? Now we use the Arthrex Gelpi retractor, which is 90-degree angulated and is very convenient. You introduce that Gelpi retractor like this way. You turn it 90 degrees and you start to expose to open the split, right? You see it?
Very well. So now, you can see also the blunted tip of your GLP, and this is really important, in my opinion. If you do with the pointed GLP, you can have some trouble with the muscle.
Yeah. So the GLP retractor is lifting the superior aspect of the subscap right here and downing the the inferior aspect of the subscap. So now with my fingertip, I can palpate where my joint line is. So I know where it is. Now we're gonna do the opening of the joint line at the level of the joint line, vertical incision. So vertical incision, we're gonna do this with the blade. Never do that maneuver from north to south, because if you make a mistake, you're in danger with the axillary nerve, which crosses here. So you always open the capsule from south to north, right? So you palpate again where it is. And at that level here, we are, pince à disséquer, s'il vous plaît, opening and suction, opening the joint line. Alors, un peu moins de rotation externe, s'il te plaît, pour détendre. Okay. So here.
Okay, so you put a bit of neutral rotation at this stage, right?
Slightly less of external rotation to gain some flexibility here in the capsule. And here, I make sure I see the head of the humerus. Be careful, you're sliding there. Stay there. Right there. Push against the scapula. Now we're gonna use this Tria retractor, very specific from Lyon, but you can skip to another one. So that retractor is introduced at the level of the joint line. And now you can do the picture-in-picture maneuver here. So I'm gonna, with my left hand, I'm gonna push towards the back so that this retractor will go into the joint. And in the same time, I'm gonna rotate in internal rotation. 1, 2, 3. Doesn't work, perfect. Here we go. So now this guy is in the joint and he's doing like 90% of the job, which means that you must understand that in the Laterjet procedure, the more retractor you have in the wound, the less you see. So we're gonna remove that one. We're gonna replace that one over here. And we're gonna remove that one. So at this point, we only have 2 retractors. These are the 2 horizontal retractors. Now we need north and south retractors. So you see here the superior aspect of the subscap. So thanks to my friend Denis, the anesthesiologist, Dr. Gallet, the patient is fully relaxed by curare.
You have a fully paralyzed patient. I think anesthesiologists do an important job. Absolutely.
So we have that superior retractor, which is basically let's say a 3.5 or 4 millimeters Steinmann pin, but it's specific with this, I don't know how to say that. How do you name this? This rounded part here at the top. So very important here. You introduce the tip like 1 centimeter medial to the joint line. You follow the neck of the scapula at the top part. You stay on the bone, okay? So it means that you're lifting the superior subscap. This position is kind of, let's say, horizontal. You take your, you take your hammer and you start to pin it. And while you're pinning it, you are elevating it, you see, progressively. And here, you need to have a good bite, strong bite. Vas-y. So now we're going to use that sponge here until the bloom. Vas-y, enlève voilà. Prends ça. On va la mettre pour toi. Plus loin. OK. Vas-y. OK. So now you can you can elevate and pull, aspiration. Okay. Now, this retractor is, give it to me, strong and straight. We want the opposite. We want a long and light and curved. So we use that Colbert retractor. You can see it, the way it's curved. So the pec will be here. So we go medial on the glenoid, right here. And I'm pushing the sponge here. And take it. And now, no, the string must be underneath. Okay, perfect. And now we take the home. And now the last one, we take again the same Homan retractor. And we are going to, vas-y, poule, tiens là-dessus. The inferior subscap is over here. So I go above, I'm touching base with the neck of the scapula, and I'm sliding under the neck of the scapula. And now we can apply that maneuver here that gives you the space for the window where we want to work. So the Laterjet procedure final exposure is only 4 retractors. 2, 1 superior, 1 inferior, 1 intra-articular lateral, and 1 curved medial to open the space. Is this clear?
Perfect view.
So now
So you don't detach the labrum before you put your inferior retractor.
no.
Leave everything as it is.
So here I can tell you that the joint line, I'm just myself bent a little bit, and I am in line with the joint line. So if you see the joint line like this way, it means you're in a little bit trouble because the scapula is not in the good position. So thanks to 2 things. Number one, the towel, I mean, the little pillow I put on the medial aspect of the scapula. So the scapula is natively, the scapula is like this on the torso. When you put a fulcrum point behind here medially, so coming from lateral, you introduce the towel. So the towel will be here, and then when the patient is lying on it, it starts to put the scapula like this way. And number 2, the tip of the intra-articular retractor, when you do this, it's protracting the scapula in the right position. So it means that you need to have the scapula as much as possible in front of you so that the joint line is like this, and you're going to be able to work this way, this direction in front of you. Okay? Because one big mistake would be to place the bone block in the undesired position, which is like over the means that you're going to have your screws with an angle which is targeting medial, oblique, and medial, sometimes towards the suprascapular nerve notch and the nerve itself. It has been described. You are going to be able, in that position here, to work parallel to the joint line, so that the screws are going to be parallel to the joint line.
Another important aspect is that you have a full support behind the shoulder. You didn't remove anything at the back, right?
No. Yeah. So here we're using, now we're going to remove that kind of tissue here. So it's horizontal superior, it's vertical medial, pull down a little bit more, and here it's like a smiley, okay, like down and up again. Okay, here we go. Pince à disséquer. I'm going to show you the lesion. So here we are seeing, and I can even remove it, we almost remove it with just my pickup, the bony Bankert lesion, the lesion. So we can elevate it from here. Okay.
So you don't preserve any labrum?
Oh. Okay. Alors, let's see here. So one of the problem we have, I mean, this lady has, is that she lost as we could see it on the CT. She lost like all this part of the glenoid, anterior aspect, and she lost the cartilage here, because this is the cartilage which starts to be very thin in the front. So we've got a pretty decent amount of cartilage in the back, very thin in the middle, and nothing in the front.
Lionel, could we maybe ask the camera to be a little bit inferiorly positioned?
Oh, sorry. Ouais, toi tu tires. Ok, ouais, il faut être un petit peu plus comme ça.
And maybe the tria retractor a bit more superiorly held. Perfect.
Oh, non, c'est celui-là qui doit être plus. Il faut, en fait, c'est. Yeah, we're gonna reorientate the camera.
You have a very nice view of the anterior glenoid, but I think if we can see a little bit more the
Et Pierre,
cartilage
ici,
surface.
on pivote comme ça. Okay, we're gonna make a pivot move. Et peut-être la baisser un peu, on peut encore. On a un petit peu de marge. Ouais, pour faire comme ça en fait. Ça a l'air bon.
Yeah, that's great.
Here. Okay.
Perfect. Thanks.
So now we've got. Pas se disséquer, s'il vous plaît. Okay. So now we've got that sclerotic part of the bone here, and we need to. Non, c'est bon. We need to freshen it. So here, I'm come from lateral with my chisel here. I'm creating a little slot. I'm replacing this one more medial like this. And then in order not to dive into the bone, I'm using again the curved osteotome. So I'm in my little slot. Attends, wait for a second. Pince à disséquer. So kind of usual, the medial retractors are a little bit suffering from what you do with the chisel.
I'm glad to see we have the same problems.
Like this. Cauchois. Okay, so we take our time. Here, it's like a decortication. If you're just like if you were treating a long bone non-union, Lambot. Because we really want to create the conditions for that graft to heal from top to bottom. And yes, s'il vous plaît. And we remove that chip. So you see here, the thickness of that little piece of bone is around less than 1 millimeter in thickness. So it's large, but it's very thin. So we don't aggravate the bone loss. We're just extra-articular in the anterior aspect of the vault, let's say, and so there is no increasing effect of the bone lesion of the lesion. It's big enough like this. So encore un petit peu. You see here, I'm good here, but I'm still sclerotic here. So I'm gonna.
Did you try to be perpendicular to the glenoid when you do this step?
Okay, say it again, Greg.
You try to be perpendicular as much as possible to the glenoid when you do this step?
No, actually, I'm just respecting the orientation and just refreshing the bone, because the bone. Here we go. That's what I meant. Okay. So here we go. We've got now the good exposition and abrasion. Okay. So you see here that broad area we created there. We can have a look at the cartilage and the joint line here. Ok. Alors toi, tu vas rester comme ça pour me montrer. Okay, that's fine. So now, yes, like this. Okay. So now, attendez, je vais leur montrer. So this is a left shoulder. So basically here is the 9 o'clock position, 8 o'clock position, 7 o'clock position, and inferiorly here, the 6 o'clock position. Now I have under my eyes, I can check where the continuity of the joint line is, and I'm roughly gonna choose to be for my inferior hole right here. So in a left shoulder, this is 7 o'clock, and in a right shoulder, this is 5 o'clock. So here I come with that tool here. Ah. C'est quoi? Okay, c'est ma main? Okay, sorry. Now I'm using a drill, but before this, it's a cannulated system. So I'm in my little slot here, and with this handle, I can push against the pick.
Can we zoom out a
And-
bit maybe so we can see your handle?
You see the handle here?
Yeah.
So this tube is protecting any soft tissue impingement of the pin at this point. And here I can really push against my pick. And pushing this, you see I'm not coming from here.
Mm-hmm.
I'm coming from here. Mind your hand. Okay.
So
And
this
here,
is really useful to your orientation.
so j'arrive pas à saisir le pin. Il y a un problème là. 2 secondes. Okay. C'est bon. Okay, so here I'm pushing hard to fight against the pick. Mind your hand. Yeah, thank you. And I'm going through.
Lionel,
Yes.
what direction are you aiming to? A little bit superiorly or just completely
Yeah.
horizontal?
A little bit superiorly inclined, like 10 degrees.
All right.
So now I come with the long drill over my pin. And you see it's completely protected. Enlevez le bistouri, s'il vous plaît. Okay. Now, very easy. I'm going through, knocking at the door. This is quite short because of the bone loss, of course. Je pense que ça va être 30. So at this point, you can make some measurement. I usually don't do it, but I can do it for you. And it says around 20, plus the thickness of the graft, plus the fact that we're going to have some compression. So my minimal size is going to be 30 here. Okay. So usually it's 34 in men, around 32 in women. But here, because of the significant bone loss, it's 30. Now, we come back. We just drill that inferior hole. We don't do anything else. Because if you try to make now, you're going to be trapped. And I'm going to show you why it's not good. So now we need to have a grasper. Forte. Okay. No, forte. La forte. Okay, merci. Now, the bone block is back on the pitch. Yeah. Okay. We catch the bone graft. We catch it here. Yes. Okay. So it was protected by, take the strings, please. Okay, behind. And now we go. Okay. Here is the bone block back in the game. We catch it again with the bone block grasper. Ici. Pardon. Pince à disséquer. Forte. So, again, we catch it from the top. Right here. Now, we drill the inferior hole in the glenoid. So the pin, I go through the inferior hole and I'm going into my hole I just drilled. That's it. Now we're gonna screw. I like to put some betadine here because we might go in contact with the subcutaneous layers where the Cutibacterium acnes lives. Pince à disséquer. Okay, I'm gonna push those tissue here to avoid any contact. And now we are screwing the inferior screw. So this is titanium low profile head screw, 4.5, partially threaded. Now that we are touching base with the bone here, we're just gonna aspirate the liquid here. We release the grasper. I'm now pushing my screw. So flex the elbow to relax the conjoint tendon. We make sure that the CA ligament is not gonna be behind. Sorry, here. Okay. And I grab I counteract the clockwise effect with my hand, with my pickup here, and I let the screw position my bone block. So you start to see that the bone block is coming to this way. I'm sorry, unzoom.
It looks parallel to the glenoid.
So it's here. and it starts to be in contact with the inferior glenoid like this way. But if you don't counteract the clockwise effect, it can go oblique and be overhanging. Grand ciseau, médecine boom. So to do so, you can also use the long scissors. You check the position with the scissors like this. Okay. And whoops, so not, you see, you play on the axis of the inferior screw, and there you go. So now I'm a little bit too medial. Here we go. Okay. And I counteract my clockwise effect. Okay. So 2 fingers technique at the end. I don't want to go through the bone block and break it. Now I remove my pin. Sorry. Okay. When I check again that I'm happy with the position of my bone block, so in line with the joint, the lateral aspect is in line with the joint line, especially the cartilage, and I'm flush with the bone. And now I just have to go through my superior hole. So that's the rationale not to perform before this, to perform the glenoid superior hole right away, because if you make a mistake, then you are trapped, and you cannot do 2 or 3 holes into the glenoid because it's going to be very wide and large, and then the screw will not hold your bone block. So then I just have to go there, going through the superior hole. Okay. Now I'm touching base with the first cortex. I'm going through, parallel to the joint line, parallel to my first screw. Here we go. And it was already through. Okay. We go there. We go there. So here the defect is very large. Ouais, ça va être 30 aussi. Ouais.
Short.
Yeah, super short, but the defect is massive.
I think it's better to measure rather to have a too long screw at the back, right?
Yes, and when you've got your measurements, you need to decrease because you're going to have the compression effect. So
what is your rate of, sorry, Lionel, your rate of screw removal?
In the series I published was 5%. But this is probably because I've got a lot of rugby players and they go back to muscular strengthening and all these kind of exercises, and they are at risk for irritation there, let's say. And but now,
and do you think it's more the head of the screw that irritates once the bone has resorbed, or it's more the tip of the screw at the back? Both?
I have no scientific answer.
But we were talking about using a superior resorbable screw, because once
I did that.
Resorb is proud. Yeah, what's your opinion on that?
So I did that in some cases, but the problem is that the current absorbable screws that we have are made of PLLA, and we know that the resorption of the PLLA creates, unfortunately, cysts into the glenoid, and this is not a good idea, I think.
There's Atachan from Turkey who asks if you ever use some Laterjet plates, the little low-profile plate.
You mean the Giacomo plate?
Yes.
Yeah. I must say I'm not using it because I get the compression I want with 2 screws, and if the patient has pain, for me it's going to be a little bit more even difficult to have to remove that 2 screws plus the plate. And if we've got some problems, we never know where that plate can go. So I'm not a good fan, but you can have a different experience. So here I just put the inferior suture in my inferior CA ligament. Now it's time to remove the retractor here. and we're gonna put some abduction here and external rotation. So in external rotation, with the tractor that went away, you can see that the flap of capsule here is back and flush to the joint line here. So now we take the needle holder, pince à disséquer, s'il vous plaît. And that coming from the top, we are going to the inferior capsules right here. Non, c'était mieux. Okay. And I'm going to tie that in external rotation, full external rotation. Here we go.
Lionel, I've
Yes.
been reinserting the labrum now on the CA ligament. What is your opinion on that? Keeping the labrum and retensioning it on the CA ligament.
I did that years ago, and I didn't see any difference. It was making the procedure a little bit more difficult to see the joint line correctly, so I stopped it. I was really believing that the proprioceptors that we were keeping in the labrum were very active and beneficial, but I didn't see any difference, honestly. So we do the same now at the superior aspect. And we go there and close the capsule. Ciseaux à fil, s'il vous plaît. Okay. Good. On va laver.
Lionel, I had some cases where I did not reattach the CA ligament to anything, and I didn't observe any different clinical results either. Do you think it's an important step, or would you be happy sometimes to just leave it and don't reattach it to the capsule?
To close the capsule?
Yeah, just leave it as it is.
So this is a question that we have now. I agree that it might not change a lot of things into the stability results. The one thing I know is that, so now I'm gonna, you see why I tagged that sponge? It's because now it's very easy to remove. The one thing I know, so I like to put, sorry, I put a little trick. I put a hemostatic sponge medial to the coracoid process, to the bone block, pince à disséquer, because the periosteum can bleed, okay, here. And I like to have that guy working for me inside the wound. Number one. Number two, we remove the retractors one by one. Now, enlève ça. I will answer your question. Don't worry. So here now here, Richardson, and now we see, so here I'm retracting the pec major, and you see the super subscribe right there. I didn't even see it there, and here is the muscle. And now we remove that sponge, and you can see that it did a good job regarding the hemostasis here of this here. Nevertheless, I put another hemostatic sponge and I leave it there. Now, I don't know if it's voodoo or something else, but I'm putting some vancomycin powder into the wound.
Do you do this systematically?
Now, yes, I've been doing this for the last 3 months, let's say, remove. Didn't have any infection so far, but I don't know if it's because of this or not. Okay. And that's it. So you see here,
Beautiful.
Outside view, full external rotation on zoom. Ouais, faut dézoomer complètement. So I'm not gonna limit any external rotation in the post-op course. You see here, full external rotation is available, is possible right now. Would it be elbow at side or in abduction?
You are really confident for some early rehab with no restriction.
So when we say early rehab, in my words, it's different from everything else, I think, because we don't do any rehab. In fact, we just
early mobilization.
teach the patient. We just teach the patient to self-stretch and to self-mobilize their shoulder in the upward direction and in external rotation for 3 months until the bone block is healed, and that's it. And if we do prescribe any physiotherapy, it is after 3 months when the patient came back to the consultation and demonstrates, let's say, between 90 and 100% recovery of range of motion just by the self-mobilization protocol, very easy. And number two, showing that the bone block is healed with a Bernageau view.
Okay, no CT scan, yeah.
You can do a CT scan, but if you have a radiologist that is used to do the Bernageau view, which is a very specific axillary view, under fluoroscopic control, you have full access to the data of your bone block being healed or not. But if you don't have it, you can go for a CT.
Yeah, that's a great way of being cost effective also with avoiding extra radiations, a good X-ray.
Right. Yeah.
And then there's a question, sorry, from the audience.
Yes.
Before we move on, is when would you consider doing a soft tissue procedure like a remplissage if you have a large heel tax defect? What is your threshold? If you can walk us through this, your algorithm.
No. In our experience, we don't have any need for heel sac remplissage in the Laterjet procedure in the same time as this procedure.
All right. And if you have a patient with, let's say, maybe a bit less controllable seizure, or if you want to be a bit more safe, this is another question from the panel. Would you consider doing a hidden Ebinet graft, so taking iliac crest with no muscle attachments on it? Or is this heresy?
No. My first option will be a Laterjet.
Well, Lionel, you did a great demonstration. It looked really easy, and you spoke to us through the whole procedure in less than an hour. So congrats with that.
Thank you so much. Hope everything was okay. Thanks to my team, anesthesiologist, my PA, my assistants, Lucas from Brazil, Antoine from Belgium, and all the other fellows who are here, Ryan from the US, Alba from Spain, and sorry, I forgot, Nila from India. Sorry.
Very
and
international
of course,
crowd.
A big thank to the Arthrex company, and especially Pierre Lefebvre, who was the guy behind the scene, and he did all these things happen all together with the team here from the Hopital Privé Jean Mermoz to open all the web portals and going through the security portals, because you know that it can be a problem in connecting the network of a hospital with the outside. So a big thank to everybody to make it possible, and also a big thank to you, Greg, for inviting me, and to the SECEC and the shoulder community.
Perfect. Thanks a lot, Lionel. See you soon. So we can go back to our conclusion slide now. So I hope you enjoyed this demonstration of a Laterjet procedure. It shows you that it's not that complicated that it looks like, but you need to follow all the steps. And I think this was the best demonstration that you could have regarding this part. So please register to SECEC. If you're a junior, which is less than 32, it's for free. You can be a junior member. And come to Rotterdam. You have to come to this conference. It would be an awesome SECEC meeting. And also there will be some special discounts for our members. And the last event will be the OSES, the Online Shoulder and Elbow School. And this will be with Samuel Antuna and Joydeep Padnis on Thursday, July 3rd, 8 p.m. Don't miss this event. So thanks a lot, and see you for the next episode.